Well, hey everyone, it's Andy Prisco and coming to you from the board of Hope Reform. And I am super excited to have this conversation with fellow board member and global expert, Dr. Kevin Huckshorn, on workforce wellness today. Before we get started, let me just talk a little bit about why we're here. Hope Reform is a nonprofit registered as a 501c3 with the federal government and as a charity in the state of Washington. What does Hope Reform do? Hope Reform is an accreditation and certification body for organizations that offer crisis services, either in community or in inpatient settings. Very often, these organizations are very small. They are not subject to regulatory oversight, and they don't get the technical assistance that they need to reach standards of excellence in how they carry out their care. Hope Reform is there for them. We are not a pay to play organization where you buy a membership and then acquire a certification. These services are funded from other sources to eliminate the profit incentive of certification, which we think is a very important value. Last year, our sessions for the Raising Anchor 2026 conference were behind a paywall. This year, we've changed that plan. All of our content for the virtual conference this year is free to consume on YouTube. And there are links down in the comments area of this YouTube video that invite you to make a donation if you feel moved to do that. And we hope that you give that some consideration. And with that, I'm going to pitch to Kevin Huckshorn. Kevin has been an inspiration to me and many, many other people across the world in raising the standards of excellence in how we support people in human services, whether that be psychiatric care, residential treatment, juvenile justice, adult corrections, public safety. I don't know of anyone who has touched more sectors on that subject matter than Kevin. And she remains very active today in addressing large problem sets, no matter what sector they're in, by bringing forward the 6 core strategies, which is the only evidence-based practice there is on reducing seclusion and restraint and violence in systems. But we're here to talk about the other observations that she doesn't talk about often enough, and we're excited to host that. And that is the wellness and well-being of the workforce. Kevin, welcome, and thank you for being here. And thank you for being a board member on Hope Reform.
Well, thank you, Andy. I'm excited to be here too and to present on your podcast or conference.
Yeah, I couldn't agree more. And I think that you you have a unique experience, Kevin. You've been the director of a number of systems across sectors. You have advocated as a consultant or worked in collaboration with the court and legal systems. You've served in a number of capacities. As you look across the workforces today that are decrying moral injury, fatigue, the word burnout is getting thrown around a lot. What are your thoughts on the motivations for that have persisted over the years? You know, we've been hearing this for a long time. Work shouldn't hurt, so forth. What are your thoughts on the areas that present the most difficulty to leaders who are trying to move the needle on that?
Okay, and I want to make clear that we're talking about behavioral health.
Oh, yes, by all means. Yes, please. Yeah.
Especially inpatient residential. Well, the first one is violence. You know, the folks, our staff that we hire that spend the most time with the people we serve, whether they're children, adolescents, or adults, are often the most poorly paid, the least experienced, have the least training. And we expect them, and often working for minimum wage, to put themselves in situations where if the organization has not responsibly done their work, these staff are victims of violence fairly commonly. And when you can make the same amount of money going down the street and working for, Papa John's Pizza or McDonald's or pumping gas or whatever, that's that's not fair, and no wonder. So what that does, of course, is leads to very high turnover. what that does in on top of, the high turnover issues, is that it exhausts the staff that want to stay, that are loyal, that have been in an agency for a long time, that have the most historical and clinical knowledge, and they get tired.
Yeah.
So that's kind of a conundrum that we've been facing for many years in behavioral health. And then on top of that, we saw a 60% loss of our workforce during COVID and after.
Yes.
And
Yes.
now what we're up against often is that, when you don't have enough bodies to stay open, our leaders often just hire people that can like walk and chew gum.
Yeah.
And that's not good enough in many of our agencies and our treatment environments, because we're dealing with some of the most vulnerable, complicated people who are experiencing signs and symptoms of serious mental illness and serious emotional disturbance, developmental disabilities, substance use disorders, co-occurring disorders. So it's kind of a recipe for incredible challenge.
Um, I think I think the problem set that you just described so succinctly is exactly that. And I would add, what doesn't help, Kevin, I think, are um, representations that, let's say, human resources might engage in on outreach to attract talent when they're not being forthcoming about what the conditions are.
Yes.
And as a result, we're attracting the wrong people, um, because they're not aware that they're walking into a situation that's going to really stimulate their nervous system. You and I just had a conversation with a system, we won't name them, but one of the challenges that they presented was that the workforce, they have enough people, but the conditions are so severe that they use unscheduled leave after working doubles, and
Yep.
they're caught in a cycle that they can't seem to get out of, even by incentivizing talent with money, hiring bonuses. They that to your point, the violence is what's driving people either out or into a state of fatigue where they work a double because they've been mandoed, and then they naturally call out on their scheduled day off.
Right.
And to some extent, there may even be some design in that. Well, at least I'm going to try to get paid time and a half if I have to do this, you know?
Right.
So you raise an interesting point. In all these years, would you say that wages have been a considerable, like, have you seen some systems do well because all of their people are paid very well?
Unfortunately, no. I would say probably the best paying systems are in the Northeast and maybe around California. But in general, the workers I'm talking about are making minimum wage or just above. And our peer support workforce is another workforce that's so extraordinarily valuable.
Yep.
And that workforce in most every state where they are certified has had to go through pretty significant training and to get that state certification.
Yes.
I'm always appalled when I see they're even making less.
Yep. And
They-
there's ceiling. They
Yes.
can't move vertically in the
Right.
organization.
There's no career ladders.
You,
So
you
that's,
know,
I'm old. So when I was coming up in behavioral health, we had career ladders, we had tuition reimbursement. We had a lot of encouragement from our supervisors to go back to school. We had a lot of in agency training, staff meetings. Everybody used to go out after work. I mean, when I think back on how that it was then, there was a camaraderie. You had a
yeah.
support system, and I'm not sure that exists so much anymore. And if I think back about other than the violence, some of the other, I guess I would say, challenges in staying in our field, is another pretty common situation where if something goes wrong, we blame the staff. And we don't look to see if it's a systemic issue. Now,
Right.
I'm the first one to say, I mean, as a supervisor, I was trained to do everything possible, bend over backwards, do it 5 times to help each of your staff be successful and productive. And only then do I get to have a conversation about maybe this isn't a good job fit.
Yeah.
Nowadays, because of the litigious and liability issues that are occurring in this country, the minute something goes wrong, someone gets thrown under the bus and everybody else watches that. And even though it may be a systemic failure or a policy issue, nobody often dives deep enough or does a rigorous debriefing about what happened to really figure out how to avoid it in the future. And instead you lose another staff or two.
Yeah. And the staff, Kevin, to your point, carry a fear burden
Yes.
where it's constantly influencing their decision making. You know, I won't name the police agency, but there was an interesting phenomena I was on the periphery of where there were claims being made about a reduction in a certain call type by a public safety agency. And um, it was a product of some, let's say, local political initiative that they were making some assertions about. Look at the call reduction of this particular kind of call our police don't have to respond to anymore. And what we learned is that the police agency, the police were deliberately avoiding those calls and wanting nothing to do with them because of the risk exposure they themselves had in responding to the call. And the politicians were making the claim that calls have been reduced, and the data revealed these people were terrified. They didn't want to get jammed in a lawsuit, their certification being questioned, so they were inconveniently unavailable for those call types. And
think about who they're unavailable for, who's left holding the bag, who
right.
has no recourse. I mean, what do? They say, I'm not staying here.
That's right. That's exactly right. And
I worked in an agency where the police had basically quietly decided that they were not going to respond to calls anymore because they decided it wasn't their responsibility.
bailiwick, right?
Yeah. And for all those reasons you just named.
Yeah.
And the staff were terrified because they had not been given the training or the tools to manage what at that point were children, adolescents, and they literally didn't know what to do, and they were afraid of getting in trouble and touching kids or having to use any kind of coercive maneuver, even in imminent danger. And so people got hurt.
Yeah. And to your point, Kevin, it's when we do the deep dive and we analyze what's happening that we see many of these systemic issues. And this is not a criticism of leadership. It's just an observation that these issues rest at the leadership level and they require leadership intervention for downstream implication. You know, Kevin, one of the things that I have always been fond of in the 6 core strategies is why you selected the first one, leadership toward organizational change. If you don't have that, all of the other things, seclusion, restraint, reduction tools, use of data, workforce development, peers, debriefing, that all goes out the window. So let's say we have in our audience workforce members and even senior executives who are resonating with this message. They're part of a larger system. They agree with you. They don't want to abandon their kids served, adults served, people served. They don't want to abandon them. But work is not a fun place to be right now. What do you say to those people?
Well, the first thing I say is identify the problems that you're having, identify what your priority issue is that you want to address. Go to the literature, find the best practices that could help you. Don't be shy about asking for help because there's no reason to reinvent the wheel. For instance, in terms of, the 6 core strategies is really predicated on the public health prevention approach. And what that means in terms of seclusion and restraint is if you wait until someone is escalated enough to meet the threshold of imminent danger, you have to put hands on. We're not talking about eliminating seclusion and restraint, especially in crisis services. What we're talking about is preventing the conflicts that lead to the violence, that lead to the imminent danger, that lead to having to put hands on. So what we're saying is go upstream, and our primary prevention part of that, the cornerstone of that model, is developing an environment of care where conflicts are least likely to happen because people feel safe, they feel
Thank you.
welcomed, their unmet needs are being met, they have a voice, they have choice, and their environment, their physical environment, is comfortable. The secondary prevention strategy is if something starts to happen in your unit, that staff have been well trained to know the people they're serving, so that if they see a change in affect, in mood, in physical movement, that they immediately go check it out.
Yeah.
You don't wait till someone throws a book across the room or kicks over a TV.
Yeah.
Because in my experience, 99% of people escalating to the point of needing physical intervention does not happen in 3 seconds.
Right.
There's a
Right.
ramp up. There's a ramp up sometimes that starts 3 days ago when mom didn't come to visit,
Yes.
or 2 hours ago when they had a bad phone call or their girlfriend broke up with them on the phone, or another patient came over to them and said, I'm in an opposite gang and I'm going to kick your ass. Whatever it is, it's knowing the people you're serving well enough to know if something's changed in the milieu. And the way you do that is, some of this stuff is so simple. When you go on shift, I'm a nurse. By the way, I should make that disclosure. I'm a psychiatric nurse for like 40 years. When I go on shift, I immediately make rounds and I check in with everyone and I do a face affect check. So I know Andy's looking serious today because he's doing a recording, but he also seems to be in a good mood. He's talkative, he's active, he's acting like the Andy I know. If I come back 2 hours later and I see Andy like
Yeah.
looking mad, or drumming his hands on the wall, or pacing up and down, or talking like nonsense, something's changed. Do something. Don't wait. Intervene. And if you
God.
have a relationship with Andy, which I do because I've been his nurse for the last 4 days, I can say, Andy, hey, Kevin here, what's going on? You look like something happened since I saw you this morning at 8 o'clock. You want to talk about it? Go for a walk? Want to play some checkers? You sure you're okay? It's stuff like that. Customer service, personal relationships.
Kevin, I love that you've always said that over the years. Customer service, customer service. And to the extent that you mentioned this point first, which I think is so brilliant, environments that are safe, environments that are comfortable. Our dear friend James Sporletter would refer to that as psychological safety. What are your thoughts on creating, in a culture where there has been little or none of that, how do we create team cultures, unit cultures, institution cultures of psychological safety? What are the core tenets of creating a safe culture where people can freely express vulnerability, getting caught doing or catching someone doing something right, celebrating that without worrying about how it impacts all the other people? What are your thoughts on how to kindle that in a place where it does not exist?
Well, I mean, you'll find most of those action steps under what I call trauma responsive care. With an understanding, what that means is that 98% of the people coming into care in any of our behavioral health settings, public sector especially, have had significant experiences of trauma. Add to that, the minute they walk in our doors in inpatient or residential, 60% of these people have been brought against their will. So
Yep.
you've already got a heightened sense of unfairness, of anger, sometimes rage, feeling misunderstood and terror. Okay, so you add that into the environment, and now you add that into an environment of staff. 50 to 60% of the general population has had some pretty significant traumatic life experiences, which means that these staff, unless they've been trained, are also very quick to escalate, to trigger, to want to control the situation. And so without trauma-informed supervisors and leadership, you've got a combustible mix going on.
Oh
So,
my gosh, yes.
so the first, what I always do, I mean, for me, with staff and with the people we serve, is give them license and a safe place to talk. So I used to go visit my staff or make rounds when I'd be serving in whatever capacity, nursing director or the assistant director or the director of the hospital. And I would just go around and say, tell me how this could be better. Tell me how your job could be better, how you would feel more comfortable. What training do you need? What resources do you need? What would make this a place where you want to come to work every day? And the same with the people we serve. How does it feel to be here? What did it feel like when you walked in the door on your first day of admission? Asking families, especially with children, adolescent kids that are in care, what was it like? How did you feel? Did you feel welcomed? I often feel like if the public behavioral health system had to exist on referrals,
Oh,
we'd be out of business.
I
We,
couldn't
we,
agree more.
we missed the entire boat on customer service. Not so much our fault in a way, because most organizations and agencies that got into customer service early were doing it to live, because they had to attract more customers than their competitors.
Yep.
And so, you look at Disney and you look at Marriott hotels and you look at even Walgreens and CVS, places you go to every day. They had to focus on customer service, and so does now do general medical facilities when there's a number of them in your locality, and you can pick where you want to go. With behavioral health, most of the time patients are brought to the nearest
Yeah.
admission door against their will. And
We
so we always had too many patients. So why did we care if they were like comfortable or not?
right,
We didn't even think
precisely.
about it,
Yeah.
And now that's led to overuse of the use of seclusion and restraint, feeling that your job is to enforce rules and control behavior, which nothing can be farther from the truth. I
Yep.
mean, just the practice of, well, I hope they come to their treatment team, but if they don't, that's okay, because then the meeting will be shorter and
Yeah.
we'll find them somewhere later and make them sign it. Well, why do you think then the folks that we've just spent thousands of dollars on a week admission throw out their treatment plan and don't do anything on it? Because they didn't have any part in it, in developing it. A human being, I don't care if you have a mental illness or you don't, human beings are human beings. And if they're not included in their plan of care and they don't agree with their plan of care, they're not going to follow their plan of care.
Yeah.
Period.
It's like the system fights the existential, unquestionable realities of being human. Like the idea that suddenly my autonomy and purpose have been evacuated because I've become part of an involuntary human
Yes.
services or mental health system. And I wonder, Kevin, it, is there potentially in the future, because I think even privatizing systems just moves the mindset from we are our own um, we are our own system, but we're just going to let someone else operate it. I wouldn't say privatize is the answer, but is there merit to the idea of free enterprise in behavioral health for the future? Is that something that could potentially break some of the patterns that have persisted for so many years? I genuinely don't know. I'm asking what you think about that.
That's a great question, and I'll tell you why. Back in 1997, the state of Florida's legislature ordered the state of Florida's alcohol, drug abuse, and mental health service system to turn over one of their 350 bedded adult state mental health hospitals. First one in the country. They put out an RFP. They were not happy about it, as you can imagine.
Oh, I
They
bet.
were embarrassed, but the legislature had determined that after spending tens of millions of dollars trying to fix the hospital, and without any real good outcomes, that they had no choice. So a company called Recovery Solutions responded and got that RFP. And I was invited to go in as part of the team to do the takeover. And I remember, because I'd worked for the state of Florida for almost 8 years by then, and I remember thinking, well, this is either going to be a terrible career move, because everybody was saying, oh, this is a private company, they're for profit, they're just going to come in and take the money and run, and it's going to be a disaster, and all the staff are going to quit, and blah, blah, blah. So I thought, well, this is either going to be a terrible experience, or it's going to be a really interesting experience to see if a public-private partnership works. And so I joined that team, and we went in on Halloween night in 1998 and found picket lines, of course, and very scared patients and very upset staff. And within a year, we had reduced the use of violence and seclusion restraint by 95%. We had started to build a brand new hospital. This was a falling down hospital, a brand new state-of-the-art hospital that was done a year later. We got Joint Commission accreditation for that hospital, the first state hospital in Florida that ever had Joint Commission accreditation. In
My God.
We kept, I got to remember, 65% of the staff, retrained them, got put in person-centered planning and recovery, psychiatric rehabilitation services on the model of Bill Anthony from Boston.
Sure, I remember. Yeah.
Changed our supervision process, made our quality improvement process a performance improvement process where we posted data every month and it was completely transparent, and we brought in peer support specialists. And that was just a little bit of what we did, but it was a resounding success. And as a result, that same company is still running South Florida State Hospital and is running a number of other state hospitals in Florida and in other states. So that was, and what I can put that down to for and it's not for everybody. The privatization issue is not for everybody, but in this particular situation, we were able to raise the salaries of staff.
Yep.
Lost money for 2 years, but we were able to be very nimble. One of the things I remember, we immediately put together an adult patient advisory committee. And in the first 6 months they were there, and I used to go to it. I was the assistant hospital director at that place. And I used to go to this meeting along with a lot of my colleagues. And I remember one of the patients saying, you know, this is a huge campus and there's all these paths, and we never get outside. We'd really like to start a bicycle club. And I said, okay, well, okay. It was like this big campus in the middle of Pembroke Pond, Fort Lauderdale. So, and I said, okay. And I said, well, what do you think you need? And I said, well, we need about 20 bikes and helmets. And I'm thinking to myself, yeah, when it snows and to get this stuff, or it's going to take like 5 years. So I remember walking to the CEO's office and I said, Sal, we've had a request from the patient advisory board. They would really like for us to get 20 bicycles and 20 helmets. And I think this is a great idea because we were already seeing the effects of some of the new antipsychotics in terms of weight gain.
Yeah.
Said, you know, it's safe, you know, we're enclosed, you know, there's gates, fences, whatever. And I said, but I know this might be ridiculous. And he reached into his desk drawer, pulled out his corporate credit card and handed it to me. And I had those bikes from J.C. Penney in 1 week. That's just an example of what a state can't do. And just to let you guys know, I was the commissioner in Delaware for 5 years. So I love state systems, and I mostly worked in public state positions. But I'm just letting you know that there are definitely upsides to privatization in terms of being nimble, being able to move very quickly, being able to spend money very quickly, and those kinds of things.
Kevin, how did you, when you that Halloween night when you saw scared patients, you were walking across a picket line, and there were great gains within a year. Um, were there occurrences where, let's say, your curiosity as a leader about employee experience um, was shown to you as something that they had not experienced before? Like, in other words, your interest in the employee's experience at work was something new to them, or was that not, did that not show up? In other words, I'm wondering, did you introduce or usher different leadership principles into the environment that allowed it to thrive so quickly? And what were those?
It's hard to piece apart because there was so much excitement. There was media coverage. Everybody was kind of at a heightened level. And what we did those first couple of weeks is we lived there, and we just were the leadership team, and we just wandered around the units, got to know. And I'm not saying that the past leaders didn't do that. I don't know because I wasn't there. But we wandered around the staff. We wandered around the units. We got to know the staff. We got to know the patients. We did right. It was, it was still, it's Florida, so it was still nice weather. We did some barbecues. We brought in pizza at night. We had a number of town hall sessions. We introduced them to their new, middle management team, and many of them were already in place. But the difference was we had meetings, like constant meetings, to get feedback on how everybody was handling this turnover, this huge turnover. My peer support specialist, after the first 6 months, Gail Bluebird, is when we really got a handle on what was going on with seclusion and restraint. We didn't jump in and start yelling at staff and say, stop doing that. But Sal, my boss, came to me and he said, we really need to reduce the use of seclusion and restraint, like right away. And I'm thinking like, well, that's nice to say, but I have no idea how to do that. Like, I had no idea at all. I'm like, what? He goes, oh, I'm sure you'll figure it out. I'm like, well, I'm not
Thanks,
sure
Sal. Yeah.
and there was no internet like it is now. Like, I had
Right.
there was nothing to
Where
look
do
at.
you go? Right.
Right. And so I thought, well, let's find out the cause of the problem first. So, because I figured something must be causing people to get upset. So they ended up in seclusion restraint. And of course, back then I'm a nurse. I've been a nurse for, 2 decades. And I'm thinking, it's medication, or it's their symptoms of their mental illness, or they're bad people, or they're antisocial disorders, or whatever. So I sent Gail Bluebird out, who was also a nurse, who's now kind of a living legend.
This is with your list of things.
And
This is
she
great.
came back 7 days later. I told her to do nothing but go on the units and come back and tell me why were patients, getting upset during every day. Like, what was happening? Why weren't people happy? Like, it's kind of a stupid Pollyanna question, but I really wanted to know, why aren't people happy to be here? What is going on in the units that is making people unhappy, and maybe even worse than unhappy? She came back 7 days later with an entire legal pad filled up. And she basically said, this is why people are not happy. And I mean, I can't even remember all the things, but started with, wasn't enough food, and it was crappy food, and people weren't allowed seconds. Nothing to do all day. Staff were not very nice to, some of the staff weren't very nice to the patients, and people would go up to the plexiglassed in nursing stations and knock on the door, and people would just ignore them. There was one phone on 30 bed units, and 2 hours during the day that someone could make a phone call. So if you didn't make your call within 2 hours, you were out of luck. There were 2 TVs on a 30 bed unit. So if you weren't like in power, if you weren't one of the patients that was either really big or scary or whatever, you never got to watch a show you wanted to. Their doors were locked during the day to keep them out of their room. Somehow that would make them want to go to group. Wrong. You had to earn the ability to listen to music or go for a walk. And it just went on and on. There were the staff had taped red lines in front of doors, like the med room, the nursing station, the exit doors, with signs that said, do not step over this line. Or what? Like there's this like threat there, right?
Right. Right.
All the signage on the walls was what you couldn't do. Don't do this, you can't do this, you can't do this, you can't do this. Their PA system was blaring all the time. Dr. Lewis, pick up your phone, line 4. It's like, who wants to live in that? There was very little access to outdoors because there wasn't much outdoors but scrub because it was Florida. And oh, by the way, I forgot to mention there'd been a drought that year and they turned off all the sprinklers. So it was
Oh my gosh.
like barracks in a dead on a dead couple acres. So it was not recovery oriented. It was not any place that anybody would want to be. So anyway, she brought this back, and I'm like, well, we have control over all this stuff. Duh. So we just started fixing it.
Going down the list. And isn't it interesting that as you got upstream to prevention, all of those negative outcomes went away? You
Yes.
know, our mutual friend, Andy McDonald, who adores you and loves your work, said during his session, we are bad at taking our own medicine. He actually said that.
Mm-hmm.
So, um, when you were, you know, because I'm envisioning people really resonating with you here, Kevin, saying, yes, that describes my place. Yes, that describes my colleagues or my leader. I want to see this place do better. What can you say to this person who um, has a desire for things to become that? What can they do to better attend to their own sense of purpose and autonomy in a place where that's not invited? You know, because what you just described on the list, intrinsic within that is almost like a staff apathy to people served in some of those examples, like
Yeah.
coming up to the glass and not getting an interaction. There are some people who are at, we know this, there are people who are like that today in
Mm-hmm.
juvenile justice, adult corrections, psychiatric care and services. They're there. But not everybody is that way. There are people who
Right.
want it to be
Oh
better.
yeah, absolutely. Yeah, yeah,
And
yeah.
and yeah, we're definitely aligned there. So what do you say to the person who's desperately looking for something to be hopeful about on how to move that needle?
That's a really tough question because as per the 6 core strategies, this stuff really needs to start with leadership, the executive team. It's really hard for an individual person to make this kind of change. But if you're willing to try it, the first thing I would do is I'd focus on your own unit, your own small space, and I'd
Yeah.
try and find a couple colleagues that are interested. I'd also go to Google and I'd Google, trauma responsive service systems or 6 core strategies, and get some pointers on what could be done differently. I think one of the main staff priorities should be to make sure that your staff understand what their roles are. And it's not to enforce and control. It's to support and partner with people to help get them down a path of recovery. And the only way that happens is if that person trusts you enough to talk to you about their story. And everybody comes to the table with a different story. And you have to have the courage to be able to listen to that story, not get overwhelmed by it, and then try and engage that person into their treatment. And unfortunately, that's usually not up to 1 or 2 staff, but at least you can be that little window of hope. I can't tell you how many times we've done consumer panels on what worked and what didn't.
Yeah.
And I'm not consumer, people that used to be patients and aren't anymore.
Yeah. Yeah.
They would say the nurse on the evening shift, Mary, she was the bright spot in my entire stay. And she
Yeah.
let me see that I didn't have to keep coming back here. If
Yeah.
you can make that impact, even if you can't change your organization, but you can impact that one person and you could connect them to NAMI or to a peer support service that's outside of the facility you're working in, get them, connected to whoever's doing peer support work in your community. That alone can be really powerful. because
Kevin, that's a perspective change. You're inviting people to a perspective change. It makes me think of that story. I think it was James who told it to me, um, possibly someone else. So I need some grace on recalling who. But there was a girl on a beach who had observed what seemed like tens of thousands of starfish washed up onto the beach. And she began to pick up one at a time and throw it back in to the ocean. And someone came up to her and said, "There's no way you're going to be able to do all of that. So why does it even matter?" And she said to the man, "Well, it mattered to that one. It matters to this one." And what a perspective change
yes,
that is. In other words, to alter one's sense of what a valuable goal is, how precious it is to be of meaning and value in the life of one person served. That's something to celebrate.
hmm
And I would even say to my own, um, let's say, perspective change, I was so laser focused on ending all seclusion and restraint where I was, that I became so roundly hated for it because I was interested in doing it very fast and getting it done. And after they removed me from that setting because I was just too caustic, uh, all of that stuff came right back. So the notion of ending unnecessary suffering today fast as opposed to going far together, those are two very different perspectives.
yeah,
And I had my ass handed to me because of that. I don't regret what I did. In other words, I demonstrated it could be done. The place wasn't ready for it and
right.
whatever.
That's a
But
lot of places. Yeah.
yeah, it
No,
was
but what
part
you
of
said
the
is, if you're a single staff member and you're working in an organization that maybe isn't there yet, focus on the starfish.
yeah. Oh yeah. I couldn't agree more.
Absolutely.
Otherwise, you'll just be a lightning rod. You'll be, I mean, what happened to John the Baptist? They had to behead the guy, the zealot. You know what I mean? So that's what happened to me professionally for a while. Believe it or not, I just went and visited Ron Adler 2 days ago.
Oh,
He's
from,
um, he had a terrible accident on his bicycle, so he's not ambulatory. He's in a chair. His life is very different now. But watching him apply his spirit as a lived, been a professional for a long time. Now he's got a lived experience component. He goes to the board meetings in his chair,
uh,
and it's completely shaped how he sees things now,
I bet.
um, as someone in the leadership system of care and services.
Yeah, you might
Um,
want to tell people who Ron is.
yeah, so Ron Adler is the retired CEO of a number of state systems. Started in Alaska, created a center for excellence there, came to the state of Washington, is really responsible for um, initiating what became my program, which is the Psychiatric Emergency Response Team program, which led me to Greg Smith and Kevin in my own research, where I had to find a video of Greg drinking a cup of coffee, who's on the board with us, talking to some people. And then, of course, Ron Adler directing me to your work, Kevin, at the NRI. Go read Kevin's 6 core strategies, Andy. And then that led me on a journey where we're together now. But if there was no Ron, there would have been no me, no Jumpstart, no Hope Reform. There would have been none of that. So,
Yeah, Ron
um,
was great.
he really is. And he was the last, let's say, um, the last legacy level leader that place had, which has just, sometimes things just have to happen before change occurs.
Yeah,
Ron was the last hope of that place, at least in my opinion, where conditions have just continually eroded to where receivership is, CMS left, like no one's there overseeing anything. So again, to your point, Kevin, leadership, it starts with leadership. It starts with people modeling the thing that they want the workforce to embody. And when I think of those principles that you talked about, like practically living at the facility, rounding, meeting with people, uh, inviting their perspective,
And
I have,
following up. If some, and that was it. I always carried a yellow pad with me, always, every job I've ever had. And whatever I see that need, I write, because I'll forget. And so I'm
yeah,
getting back to people. That's really important.
I believe that too. And you speak to an era of these values being so present in a leader. Um, I'm I'm actually afraid that Charlie's book he's writing, Charlie Curry's book on how care and services have been subject to political capture, is going to resonate with a lot of people because we've lost the person centered, vulnerable, moral imperative, I think, so often in systems where people want to hide their data or they want to use talking points to get around
Yeah.
vulnerabilities. And even you talking about make the data available, share the data. And where
Data
we
is
are
a friend.
today,
Right.
we have systems that people enter this work, I think, Kevin, with a natural proclivity to want to be useful,
Yes.
and
I
and
agree.
and the burden they're experiencing is not just the violent presentation of the person, but it's due to um, years of legacy level oversight and leadership that was not interested in the things that you're interested in.
Right.
And it's very hard, I think, like when I think of you as a leader, Kevin, your willingness to lean into discomfort is a fundamental requirement of a leader. To lean into personal discomfort, like the common theme that's been coming through these hope reform sessions with James and you and our Studio 3 friends. There's humility that's got to be in there. I don't have all the answers,
Right.
and um, we need to move the ball downfield together. There's no way I'm going to be able to unidimensionally just rule make um, email directives by fiat, where we witnessed that. You and I witnessed that together. So we were there on scene. Someone directives by email all of a sudden. What the hell is that going to do?
Right.
That doesn't amount to anything.
Right.
Why aren't you down there talking to the people where
Yeah,
we,
it's disrespectful.
yeah,
Um, Before we run out of time, I did want to talk a little bit about some of the strategies that individual human beings that are staff in behavioral health.
I yield my time to my distinguished colleague from
No,
North
no,
Carolina.
to be able to survive what's a really challenging work environment. And so and you guys are going to have heard this, but may or may not have kind of really understood how important it is. But the first I'm going to tell you is diet and sleep. Is you've got to get 7 to 8 hours of sleep a night. Sleep is so incredibly important. And while you're trying to get your sleep, you need to remember about the people you're serving. And if you're waking them up every hour to do 15, 30-minute or hour checks with big bright flashlights, you need to look at getting red lenses. You need to really look at that, because people do not get better if they are sleep deprived. I don't care if they have a mental illness or they don't. It's really hard. And so sleep is so critically important, and we ignore it, or we hear it and we go, yeah, whatever. It's just critically important to get enough sleep.
Kevin, there's a sleep deprivation crisis among youth in the gaming community now.
I
There's
bet.
research coming out about this.
I
It's
bet.
awful.
Yep, I bet. But then, to me, even more important is what you do outside of work. You got to have some interests outside of work. And even if you're having to work double shifts, you're not working double shifts all week. I mean, even if it's going for a walk or having a little garden patch or going to the gym or taking your dog for a walk, it's just really important to have some other interests. Watching TV, be careful what you watch. It's
Oh,
this is going to be like stupid for some of you, but Hallmark versus Criminal Minds. Think about this, guys. And I've watched both for different reasons, but you're wanting to heal yourself in between your shifts. You're wanting to get back on your balance, right? And so be careful. What you're putting in your body in terms of audio, visual stuff, because it affects you. You may not know it, but it does. And then the third thing is just basically learn to self-regulate your emotions. And if you don't know how, because we're not born with that skill, many of us are not born with that skill, you have to learn it. You will be a liability in a behavioral health setting if you don't know how to self-regulate. And when I mean self-regulate, I mean when stuff starts to blow up in front of you, you're able to take a deep breath, calm down, and think, not react. And if you've got a relationship with Mr. getting very upset dude, you're gonna hopefully be able to go over and say, whoa, man, me, Kevin, let's talk. Can we talk? Can you come away from all these people and the audience that's standing around watching all this? Can we go for a walk? If it, whatever it is, but keep being able to be calm, even to call for a code, just to be calm. Don't make it worse because you've gotten really scared or anxious. Because then you become a lightning striking here, and then lightning starts going through you, and then it starts to build. So really work on self-regulating, breathing, and it takes time. It's not something you're going to learn overnight. Watch more seniors, experienced staff, how they handle these events. If you're lucky enough to have a psychiatric emergency response team, watch them. They're the experts. You can learn so much from PERT team staff. So I just wanted to throw that in before we're done.
I always feel like I'm around a biblical figure when I'm with you. I always like I'm ready to sign up for servitude wherever you need me to go. I, I'm so grateful the world has you. Thank you so much for your willingness to speak into um, the problems that human beings have in our behavioral health systems from a place of deeply credible experience and humility and even some humor. Your willingness to share lessons learned, mistakes. Um, it's so refreshing today, Kevin. How does somebody, if someone wants to learn more about the six core strategies or getting you in to train them or make them aware, how do people follow up with you? I mean, they can certainly write
Email.
at Kevin at Hope Reform, but you
Email.
also have your own practice,
Yeah.
um, which is
It's
KAH Associates, right?
right? Kevin at kahassociates.com.
Yes. And you work alongside Janice LaBelle from the great state of Massachusetts and Greg, and you're actively involved in a number of consultations now with systems across the world. And um, I hope that doesn't change anytime soon, Kevin.
Indeed.
Your legacy definitely speaks to the way forward, and it's a great personal privilege for me to be at your shoulder and do this work with you. I want to thank you so very much for this time to talk to the workforce about things they can do to attend to their well-being. And again, all of the very best to you, and I'm sure I'll be talking to you very soon.
My greatest pleasure. Thank you, Andy, for including me.
Thank
Bye.
you. All right. Take good care.